Continuing with our previous year NEET question, 2025 PG NEET. This is a rheumatology question. So it's a big question. We'll read from the last line. Which diagnostic modality will pick up the disease process at the earliest? So the earliest investigation of choice, that is the question. A young male presents with chronic low back pain and morning stiffness and pain for 1 hour, which improves with activity. X-ray of the LS spine is normal. The patient also has anterior uveitis and clinical examination. Hope the diagnosis is more or less clear. It's a chronic low back pain. Whenever a question comes, this is a rheumatology question, whenever a case scenario comes on low back pain or joint pain, our approach is we have to differentiate between two types of pain. Whether it is an inflammatory pain or a non-inflammatory pain. Because non-inflammatory pain, the diagnosis will go towards ortho or a surgery question. If it is inflammatory pain, the answer will go towards a rheumatology. So the main clue for inflammatory pain is early morning stiffness more than 30 minutes. So early morning stiffness or pain more than 30 minutes. And pain which is more on rest and relieved with activity. Non-inflammatory will be the opposite, where there will be early morning stiffness or there will be early morning pain, but the early morning stiffness or pain will be less than 30 minutes. And the non-inflammatory, the pain will be relieved with rest and it is more with activity. So this is how you differentiate inflammatory pain from non-inflammatory pain. So the examples for inflammatory conditions, inflammatory back pain is actually rheumatology, right? So we can classify into axial diseases. Axial is anything from the spine, and appendicular diseases. The commonest appendicular cause of inflammatory pain is rheumatoid arthritis. So another question had come in last year's NEET. In rheumatoid arthritis, what is the pathology? There's something called synovitis or pannus formation in the synovium. Okay, so just an added point. So rheumatoid arthritis is the major inflammatory pain affecting the appendicular skeleton or the small joints or the limb joints. So we discussed one question. It causes synovitis or pannus formation. Other clinical clues will be it's a polyarthritis. It can be associated with other diseases like interstitial lung disease. Okay, it can cause pleural effusion. So these are some of the clues. And what is the test of choice? We have rheumatoid arthritis factor and we have another marker called as anti-CCP, anti-citrullinated C peptide. Citrullinated C protein. These are some of the clues for rheumatoid arthritis. In rheumatoid arthritis, RA factor or anti-CCP will be positive. There can be some diseases where again appendicular skeleton like the hand joints or knee joint or shoulder joint or wrist joint may be affected, but this RA factor or CCP is negative. So they are collectively called as seronegative arthritis. So if a clinical question comes like RA factor is negative or anti-CCP is negative, your mind should directly go towards seronegative arthritis. So there are actually 4 seronegative arthritis. One is axial and one is 3 are appendicular. They are psoriatic arthritis, IBD arthritis, reactive arthritis. Psoriatic arthritis, patient has a clinical question on psoriatic arthritis. Some clinical questions may come, like rheumatoid arthritis affects the proximal interphalangeal joints. Psoriatic arthritis affects the distal interphalangeal joints. So this can come as a clue. IBD arthritis, patient will have ulcerative colitis or Crohn's in the background. They will have a bloody diarrhea as the clinical question. Reactive arthritis, patient will be usually normal. They would have had a fever or UTI in the past. Our famous Ritter syndrome, the triad of polyarthritis, conjunctivitis and UTI, is also a reactive arthritis. So psoriatic arthritis, IBD arthritis and reactive arthritis are appendicular variants of seronegative arthritis. But we have the main seronegative arthritis which affects the axial skeleton or the spinal joints, which is AS, ankylosing spondylitis. So there are 4 seronegative arthritis. One is ankylosing spondylitis, which affects the spine. Psoriatic arthritis, IBD arthritis, reactive arthritis affects the appendicular skeleton. Among all rheumatological diseases, usually autoimmune diseases or rheumatological diseases are common in females, except seronegative arthritis, which are common in males, young males. So it presents with low back pain. What type of low back pain? Inflammatory low back pain, right? Inflammatory type of low back pain, which means it is more on rest, early morning stiffness more than 30 minutes, and it is relieved with activity. The earliest joint affected is SI joint, sacroiliac joint. So sacroiliac joint arthritis is the earliest imaging marker, and it is early picked up in MRI. In the later stages, like when it crosses more than 10 years, only then we can pick up the classical X-ray finding, which is bamboo spine. So this has become outdated because it takes 10 years for ankylosing spondylitis to produce bamboo spine, but we can pick up earliest in MRI. That is actually this question. See, patient is having a chronic low back pain. He is a male. There is morning stiffness and pain for 1 hour. So it could be an inflammatory arthritis, which improves with activity. Again, it is a finding of inflammatory arthritis. And it is the appendicular skeleton. It's a back pain. Spine is affected. And X-ray of the LS spine is normal. So I already told you it will take 10 years for X-ray spine to produce bamboo spine. It's a late pickup investigation. And will serology help? No, because it's a seronegative arthritis. If at all something can be done, HLA-B27 is a genetic test which may help, may not help. Maybe for your MCQ, HLA-B27 you just remember. And the associated features of ankylosing spondylitis will be anterior uveitis. In ophthalmology, please read anterior uveitis. Please see images on anterior uveitis, because so many systemic diseases are associated with anterior uveitis, like tuberculosis, ankylosing spondylitis. Then we have Behçet's disease. Behçet's disease is called oculo-orogenital syndrome. So it causes ulcers everywhere. It causes genital ulcers, oral ulcers, ocular ulcers and anterior uveitis. Behçet's disease, the gene associated is HLA-B51. So 2 genes we discussed now. HLA-B51 is for Behçet's disease. HLA-B27 is for ankylosing spondylitis. I think this will summarize most of the important questions in rheumatology and back pain. So we'll discuss the options now. So anterior uveitis, early morning stiffness, back pain. This mostly comes to ankylosing spondylitis. Which modality will pick up earliest? MRI. So will anti-CCP help? No, because anti-CCP is the investigation of choice for rheumatoid arthritis. This is actually seronegative arthritis. So anti-CCP will be negative. MRI of sacroiliac joint is the answer. CT of sacroiliac joints, no. Better investigation is MRI. Bone scan will pick up only bone metastasis, and it is used to diagnose osteoporosis. Osteoporosis is actually picked up by DEXA scan, dual energy X-ray absorptimetry. Okay.